All right, Janet, thank you very much for covering not only the past but the outlook for the future. So plenty to discuss further today. Before we get on to those panels and discussions, I want you to hear from one other very important perspective, and that's Dr. Rich Platt, who's professor and chair of the Department of Population Medicine at Harvard Medical School and at the Harvard Pilgrim Healthcare Institute. Dr. Platt is the principal investigator on the FDA's contract to develop Mini-Sentinel, the one that's been very productive, as Janet just described. Rich, come on up.
Well, it's a real privilege to be able to spend a little time with you reviewing the things that we've been doing and are doing. Let's see. Do I have slides coming up soon? So if you can bring the first slide up when you can. I'll just say that when we started in, nope, not yet. When we started in 2009, FDA asked us to do just a couple of simple things. One was to develop a scientific operations center that could support active medical product surveillance, and to create the resources that would, thank you, no, create the collaborations, the data resources, and the policies and procedures that would allow FDA to evaluate a number of specific safety problems. The other arrow. Okay, thank you. For the record, this is the arrow that points left. And we started on that with a number of the nation's leading sort of partner organizations, and we were delighted that we were joined then by another two data partners as the work progressed. Now, we started off identifying a number of needs, and it's just easy to characterize them as everything, because this was really a blank piece of paper startup operation. The kinds of things that we needed to do are develop policies and procedures, develop a data model to support the work, to create procedures at FDA, at the coordinating center, at the data partners to allow us to use these, and to develop the infrastructure that would support it. That's personnel, sometimes it's hardware, and also a considerable amount of software. This is the cartoon of the distributed data system that we have put into place. We've been careful all along to try to adopt national standards wherever that's possible, and we put a fair amount of time and energy into ensuring that the system is compliant with the query health system that's been advanced by the Office of the National Coordinator for Health Information Technology. The Mini-Sentinel is actually one of a small number of demonstration pilot programs of the Query Health Initiative. So we've been deeply involved in trying to advance the general national capabilities for distributed querying. And last year, we showed the sort of the first fruits of the work, a compilation of 30-some peer-reviewed articles that were published in Pharmacoepi and Drug Safety, describing the platform, the operational capabilities, the governance principles, and the like. Mark mentioned that we now have a large and growing distributed data set that's available for FDA to query. Like McDonald's, we're transitioning into just saying billions served. I think the most useful fact of the moment is that the data set currently has about 380 million person years of data for which we are reasonably confident that we know most medically attended events, and during that time there's a pharmacy benefit that also gives us relative confidence that we know about medications, at least as they are prescribed and dispensed in the outpatient setting and some inpatient settings. During the past year, we have made the transition from building capabilities to being able to support FDA's regulatory activities in a more active way. This is an example of a drug safety communication that the FDA distributed in November about bleeding risk associated with the anticoagulant Pradaxa. I've taken out an excerpt there saying this drug safety communication was based on data provided by the Mini-Sentinel. We've also been undertaking, this is an example of a rapid response to an FDA query. And in contrast, we've also completed some evaluations which are not so rapid. They're rapid by the historical norms of doing these kinds of studies, but they are in contrast to a very standard question for which it's possible to create a standard answer. These kinds of analyses require the development of a specific protocol. You'll see an asterisk on this slide. Throughout this presentation, if there's an asterisk, that means that there's going to be a detailed discussion of this later in the program, and Darren Toe is going to talk about this activity. When this was published several months ago, there was an accompanying editorial by the editors of the Archives of Internal Medicine saying, among other things, we commend the FDA for developing the Mini-Sentinel, seeing it as an important national resource. The availability of this capability has gotten us to the point where it has become important to address a number of issues that thoughtful people both within and outside the FDA pointed out would be an issue. That is, come the day when it's possible to efficiently ask questions of so much data, you have to be careful that a number of the things that appear in the data will prove actually not to be real or merit public health action. And so it's been important to develop a set of guidances about how to evaluate signals that arise from these rapid assessments. And so we recently posted a white paper that gives a framework for doing that kind of evaluation. The question has also arisen of how best to use a resource that represents a big fraction of all the available data that could address a question. That is, if FDA asks for information about bleeding related to Pradaxa and we do a standard analysis that gives an answer, and then FDA wants to go back and ask more detailed questions, can you ask those questions of the same data, or do you have to ask them of another data resource? And so I've gotten these backwards. This is the the white paper that looks at what do you do after a rapid assessment, can you reuse the data? And the answer is it depends. And I recommend this paper to you as a thoughtful description of how to do this. And this is the white paper describing the framework for assessment of positive results. Now, Mark and Janet both described a system that we've intentionally tried to make as user-friendly as possible for FDA, which is when FDA says, we have a question, we try hard to say, and here's your answer. And what I'd like to do is spend a little time this morning describing something of what's under the hood to make the system work like that. Because as Yogi said, in practice, what appears to be true in principle isn't always the case. So first, let's take a look at this nice diagram of how the questions go from the coordinating center through a little box to the data partners. And first, what's in this portal? The portal is in the middle of this diagram is a high security data center that's hosted in a facility in Arlington that's guarded by armed guards and is earthquake proof, and has a bunch of functions. Those green boxes are all specific activities and capabilities that are required to make the portal operate. What goes on inside the data partners? Well, a big part of what's been important to do is to create an outward face from these data partners that makes each data partner look as though it's configured in the same way. So in Tinker Toy mode, it looks like this. But as you know from the fact that Tinker Toys are built from a set of blocks like this, you can build lots of different things from them. And in fact, each data partner has built its own system in a unique way, and so a substantial amount of effort has gone into a thoughtful dialogue with the data partners about how to take their uniquely arrayed data that has unique content and put it into a form that allows a distributed data system to work. So, so with that as a preface, let me take you through an average Mini-Sentinel week, and I will touch briefly on these 6 points. The first is, how do we develop and maintain this database that turns those Tinker Toys into the vehicle that Mini-Sentinel uses? The lion's share of the tough effort belongs to the data partners, who refresh their data typically every 3 months. And they go through a standard 8-step process that you'll notice has 2 little circles on it. That means that this is an iterative process that has to be repeated as many times as necessary to get to the right answer. When they get to this step, they hand over some output to the coordinating center. And then the coordinating center has this 7-step process, and this too has a bunch of iterative steps involved. We've done 120 core data refreshes since the Mini-Sentinel began. And so just think for a second, how long do you think it takes to approve a refresh of the data set? That is, once the data partner says, we've finished updating the data set and we've run the data checks, how long does it take to say to FDA, now that data is ready to use? Okay, I misled you by showing a clock. In fact, it's 3 weeks to 3 months, depending on what the data checks show. Why does it take that long? Well, each data check results in 100 tables that have to be evaluated per data partner, and a bunch of analyses that are inspection of the data. Here's an example of visualization of the number of encounters from partner A after the 7th data refresh. And here's what happened with when refresh 8 showed up. Well, the good news is there's another 3 months of data that looks about right. The problem is that 2009 data, which used to be perfectly well behaved, now looks very strange. And so the coordinating center and the data partner thought it through, and there was a new refresh that made everything look fine. So one of the lessons that comes from this is that Thomas Jefferson may or may not have said eternal vigilance is the price of liberty, but the Mini-Sentinel says that eternal vigilance is the price of reliable data. So although we make it a point of saying if we delivered an analysis to the FDA, we can reproduce that analysis, the Mini-Sentinel data set itself is a dynamic entity, and today's version of 2009 data is not necessarily yesterday's version of 2009 data. Okay, so if we have a data set that's usable, then how do we actually respond to questions for FDA? A standard kind of question is this, comes through all the time. From this date to this date, we're interested in people who are exposed for the first time to a specific treatment, and we want to look back this many days and restrict the population to people who did and or did not have various characteristics. And we're interested in these outcomes, but we're only interested in outcomes that occur at least some number of days after the first exposure, and we want to count forward at least this amount of time after the exposure ends. And so since that kind of question arises all the time, we've built a library of what we call modular programs that can address those kinds of questions, in which it's a program that we know works, the data partners know work, and we change a variety of parameter settings to do that. So it sounds simple. So here's the query fulfillment process. It's only 15 steps to go from FDA ask a question that looks like this to our being able to give FDA an answer. So there are 15 steps, and 6 of those are iterative. They start from making sure that we understand what FDA really wants to know, to our being confident that we know how to interpret the answer, because among other things, these responses typically come from 17 different data partners, and we look across the data partners to see if they're internally consistent, and then we put the data together in a way that doesn't drive you nuts to read the outcome. And the turnaround for those is pretty short. If it's urgent, it can be days. If it's standard operating procedure, it's weeks. Now, sometimes those modular programs aren't enough to answer the question, and in that case, we write a new program. Now, the steps for writing a new program, good news, there are only 12 of those steps, but 7 of them are iterative, because one of the features of the distributed data set is each data set lives in its own IT environment. And therefore, a program that runs fine in one environment may not run so fine in another environment. So there's a lot of testing to make sure that these programs will run and run efficiently in a host of different environments. And what kind of uses do we make of the distributed database? Janet mentioned that there have been 300 and some queries. I'll show you that those 300 and some queries actually turn into thousands of actual data runs where a program is distributed to a data partner, and the data partner returns the result of that, and it gets put into, and several of those then are nailed together into the response to a single query from FDA. And we've done about 100 of these ad hoc programs where we've had to develop a new program from scratch to support the FDA's needs. Okay, so that takes care of sort of standard kinds of questions. Now let's move on to the more complicated kind of question where FDA says, we don't need the answer right away, but we'd like your best, the best answer that can be provided in a reasonable amount of time in the distributed data set about an important exposure outcome relationship. And there are 4 studies like this that have either been completed or in the field. We've already talked, we have a study on the regulatory impact of a labeling change for long-acting beta agonists, a study of rotavirus vaccine and intussusception that are going to be part of the next panel, and a couple others listed here, and a number of protocols under development. And we'll describe one of those protocols that's under development during the afternoon panel. As Janet said, there's a substantial amount of work that goes into developing and implementing methods to work in this environment. The main focus of methods development that FDA has asked us to undertake has been to adapt methods that we know work to work in the Mini-Sentinel environment. So this is real sort of implementation research rather than stand back and think about the basic structure of methodologic research. And I've listed here 4 examples of 4 of these kinds of methods that are being evaluated. By far the most challenging, and in some ways I think interesting and potentially valuable, is the work that a large group of methodologists, data partners, FDA staff are doing to create the capability to do prospective evaluation of accumulating data about relatively new products. So the successes we've had so far have by and large been either quickly or relatively quickly look back at accumulated experience and help inform a decision that FDA has to make. The complementary activity is to have a program that can look at new products as experience accumulates. Looking back, in my view, is like what Fred Astaire did. It was, to my mind, elegant, easy to watch, based on quite a lot of very sophisticated thinking and a hell of a lot of practice. The prospective stuff, I think, is the Ginger Rogers piece, backwards in high heels. It's just much, much harder to implement a prospective surveillance activity. And because of that, I'm delighted that the organizers have allocated time for a whole panel to address how that's going to work later today. We've also been attentive to building new capacity to address important questions. And here are 4 kinds of ways that we're doing that. One is in the developing this prospective surveillance, to build new sets of query tools, just to develop more bandwidth to be able to handle more questions simultaneously from FDA, and cautiously to build out the capabilities to access more kinds of data, specifically, for instance, linking Mini-Sentinel data to state vital statistics registries like birth registries or immunization registries, and we're beginning to explore ways to get a better view into the inpatient environment. The final thing that we're doing is trying to contribute to this development of a national resource to evidence development, which we see as a critical need and a unique opportunity. This was articulated first in this New England Journal perspective that FDA took the lead in writing 2 years ago, and we have a number of important external engagements. Jennifer Nelson and David Madigan will describe the work we're doing with Mini-Sentinel is doing with OMOP. Jeff Brown will cover the waterfront a little more broadly and specifically focus on the NIH healthcare system collaboratory that is building very directly on the Mini-Sentinel's work. So, in summary, I'd say there are a number of key contributors to the successes that Mini-Sentinel has had so far. By far, the most important is the close, frequent, coordinated interactions between FDA, the data partners, a large number of content experts, epidemiologists, and statisticians. It is not possible to simply write down a statement of work or to complete a protocol. There's every day there are dozens and dozens of interactions about exactly what's wanted, exactly how can this work, exactly with a data partner, will your data that looks fine for this purpose actually support this need? Because data that looks the same may have special attributes that only the data partners know about. The second was the decision to implement a distributed data network. I'm convinced that we would still be talking about how to create a pooled data set if that's the route we had tried to go down. Third was making clear that this activity is public health practice. Mini-Sentinel only does what FDA asks it to do in support of its regulatory mission, and the fact that this is public health practice has meant it's been able to operate in a very efficient and effective way. I think we made the right decision in working first with the data that had the largest and longest history of being useful for post-marketing safety. That was claims and administrative data when linked to access to full-text medical records when they're needed. And having built that capability, then to be putting energy into additional valuable sources like electronic medical records and registries. And finally, the rapid cycle development of capabilities has been very useful. At every turn, we've thought with FDA about what is the simplest thing we can do that will be useful to you for addressing a particular kind of question. And we've tried to build that and test it out. And sometimes it works, sometimes we take it back to the shop and start over. But having built something that does something useful, it's then possible to make it work better or faster or give it additional capabilities. And so that's worked much better than fully specifying a very complicated system, which sometimes is not so complicated, that answers a large number of FDA's needs from scratch. And finally, I think, has been our ability to respond quickly to needs that FDA tells us it might have. That is, the idea of these modular programs is a really good example of that. FDA said, these are the kinds of questions we expect to ask all the time that we'd like answers for within a reasonably short period of time. One of the real learning experiences that many of us had was in trying to build from scratch right away a system to monitor the safety of the H1N1 influenza vaccine. You recall that at a time between the first and second public workshop, that is, when there was no Mini-Sentinel, FDA had a need to develop a post-marketing evaluation system for a brand new influenza vaccine that was going to be used on a large fraction of the population. And many of the current participants in the Mini-Sentinel were involved in this program, which is called PRISM. It was successful in many, many ways, but it was remarkable. The signal to go came in August. There was a great deal of intense engagement, not only by FDA staff, but by the Office of the Secretary of Health and Human Services in helping to facilitate the participation of all the key data partners. Many people worked 18-hour days for months at a time to make this work, and the first data that actually came out that was useful was in February. So doing it from a standing start, even with talented people spending all the resources, personal and financial resources that they can on it, is a long process. And that makes the point to me that it's important to be prepared. And so you might ask, well, how much does all this cost? And the answer is having the database and the capability to submit questions costs about $10 million a year. That's the base contract to have the data set up and running, and that includes a substantial number of these standard queries. With that as the base, the protocol-based studies are then extremely inexpensive by usual standards. If you want an order of magnitude estimate, it costs about 10% of what historically it has cost to do large database studies to do a protocol-based study in the Mini-Sentinel environment. The value of being prepared for a pandemic, like the credit card ad says, is priceless, I think. So we've had a couple of expectations that were confirmed by this activity. One is that we had expected, and it proves to be true, that standard programs can help the VA quickly interpret signals that arise from other sources. When they say, we might have a problem, it's possible to put together the data from 380 million person-years of experience to say, well, here's the experience of a non-trivial fraction of the US population. And here are some examples that Mini-Sentinel has worked on. And we have also really been pleased to find that it has been possible to do many quite sophisticated analyses in a distributed mode, meaning that no protected health information has to be exchanged. That wasn't so clear, and one of the things that has been interesting to see is that when you ask thoughtful methodologists to modify existing techniques or invent new techniques that will let you do in a distributed fashion what has heretofore only been doable with a single data set that sits in front of you, they are remarkably capable of developing ways to accomplish these goals. It doesn't mean that every analysis one would ever want to do can be done in a distributed fashion, but we've really pushed the boundaries on that quite a lot. Most of the data that I've described here is on the Mini-Sentinel website. This is it's our repository of record. I've put a red circle around the RSS button. If you're not already subscribed to the RSS feed, I encourage you to sign up, and we'd love to have your feedback about that. I want to make sure to offer my thanks to FDA, to the many of you who have participated in building the Mini-Sentinel, and especially to the approximately 400 investigators who are affiliated with one of the partner organizations that works every day to deliver these results to FDA. So thanks very much.
All right, while the credits are running, we do have time for a few questions, and I think that, Janet, if you're willing to take some as well. As I mentioned before, the thing to do is if you have a question or comment, head to one of the microphones here in each of the, between each of the table sets. As we're getting started on this, this is a question for both of you now that we're sort of, this is our 5th workshop, 4 years into the contract, and a lot of experience, clearly a lot of progress and successes. What has been most challenging unexpectedly from your perspective? What's ended up taking some more time, some more thought? I think that part of the answer to that question has driven some of the things we're talking about during the meeting today, but I'd like to hear from you. What was the biggest surprise?
Well, my relationship to the project is quite different. All right, so take this for what it's worth. Most challenging for me is continue to raise some money to make this happen, because as Rich pointed out, although it's remarkably cheaper, all right, than traditional methods, and gets us into, I would say, a state of less uncertainty and concern, or heightened, whatever is appropriate given the results we get, much faster. So we have much more information much faster, and so I think it's really worth it. But this is not a time of large budgets for the federal government, and we did not receive any specific, funding for this activity. So I'm committed to keep this going, but I think it has been challenging, and it will probably, the challenges will increase in the current economic environment.
Well, I'll say, Mark, one of the big surprises has been how effective the partnership with FDA has been. I mean, I've got several decades of working with federal sponsors, and this is one of the most productive engagements I have ever had. The FDA team has been really extraordinary at, first of all, what they personally bring to the project, and also in their ability to work through the usual administrative barriers and problems and red tape so that we don't see it. So there are an awful lot of, so the sense has been that we've had the wind at our backs in a way that doesn't usually happen. So that's not a challenge. What's been, even though so here's the challenge. Even though we knew that it would be essential to be able to have open communications on a frequent basis, I think we hadn't appreciated just how important those are on a day-to-day, ongoing basis. The idea that there's a data resource there and all you have to do is send a question to it turns out not to be true, in fact. And so the amount of time and energy that it takes to actually be able to use the data resource in the way that FDA wants it to be used was a surprise to us, and the amount of time and energy that goes into it by very talented people on the data partner side and in the coordinating center is just been, it's every day it's a surprise about how much work it is. So I guess I'd call that a kind of a challenge to make that work. Well, let me leave it there.
Can I say an editorial comment about this? Because, I think we've heard in the past, I think the availability of all these data have been oversold as far as the ease, not by you, obviously, but by some party, shall we say, as the ease of accessing them and getting answers. I mean, it's not like right now you can easily tell who uses what brand of toothpaste, right? Because all those records apparently are accessible, and what you bought, and people can compile. And so people just say, well, it's the same. As soon as we have all the electronic data on everybody, we'll just push a button and we're going to get the answers on everything. And it turns out this just ain't the case, at least right now, and probably won't be for a long time. So I think a lot of our struggles are that there's this expectation out there, once you assemble all these data, well, you're done. and there's no ongoing struggles to interpret it and figure out how to analyze it and so forth, and that just is not the case. So that's sort of a barrier we've had to overcome, because there was a lot of conception that all that we really had to do was get these big data together, and that was it.
And both these communication coordination issues and these ongoing methods issues about kind of understanding what the results mean, those are obviously not issues that are completely resolved. We'll be talking more about some of them during the day today. Just in one further question in terms of looking forward. So, Rich, you had that slide that you put up about 5 years ago. What do we need to do? Everything. It's a blank slate. There is no difference in Yogi Berra's theory and practice because there was no practice yet. You all both talked a little bit, Janet, you especially, about looking ahead. So 5 years from now, and you kind of laid out a vision for a national data resource that could be tapped into for multiple uses going beyond drug safety surveillance questions and even device surveillance questions as well. Could you all say a little bit more about your vision for what this could look like 5 years from now? Let's assume that we keep making progress on all of these challenges. What can we expect in 5 years? Or what can we hope for in 5 years?
Well, I think that separate uses will have to be thought through quite carefully to achieve the user's goals. Jeff Brown will talk later today about our view that the Mini-Sentinel is what we call a tightly coupled network. It's important to have this ability to have rapid, frequent interchanges between the coordinating center and the data partners, not just in getting the data ready to use, but query by query, what does this result mean? He'll describe the NIH Distributed Research Network, which is now sort of funded, and we're privileged to have a role in developing that much more loosely coupled kind of activity. And so I think in 5 years, it would be entirely realistic to have multiple kinds of organizations that would be capable of engaging with the Mini-Sentinel data partners and with other data resources. I don't think it's just the Mini-Sentinel resources that would be useful there. To have realistic engagement of a wide range of investigators with various kinds of data partners. So I think that kind of interchange is entirely possible. It's not going to be push a button, though.
Yeah, well, I would like to compliment Rich Platt, particularly in the last slide. I don't think people realize, you saw all those analysts, statisticians, programmers, and everything, physicians, rolling by on that movie, on that little video, all the different people who've been enlisted. What we're really talking about, in my mind, is building a community of practice that has not really existed. And it does require funding, and what we're saying, I think, is it requires more funding commitment from multiple places and multiple sectors. But I agree. I mean, I think the data infrastructure, the reason it's seen as a somewhat of standalone is not because it doesn't need tremendous interaction with any given, coordinating center for any given set of activities, but that community practice to me is the core and what needs to be supported, sustained, and built up and have access to its own methods and expertise. And the stronger that core is built, then the more feasible it will be to have multiple partners interacting with it. But we can't, there's a tendency, I think this is among researchers in general, Mark, to just view the data out there. It's just the data, and these people just have to get it in order, and then we'll do research on it, right? It's not like that. I mean, the folk, as Rich very well described, I think, they need to own those data. They need to understand the characteristics of the data. When they do a refresh, they need to understand what's going on, why things are happening, so that community has to be very tightly linked and really understand the analyses that are done. And we would envision that governance structure between any coordinating center or whatever and this network would have to be very tightly linked, both because data partners may not wish certain analyses to be performed, and they need to have the right to say, no, we're not going to participate in that, but also because of this extreme link that is really not, I don't think, well understood outside between the data structure, understanding those data, and then the results that you get out at the end of the day. So that's what we're attempting to do, is really try to build that up.
Great. Well, I'd like to thank you, Janet. Thank you, Rich, for starting us off and helping to frame the day. Thank you very much. And now, if you look at your agenda, we've got a short break scheduled, about 10 minutes right now. Picking up on Janet's comment about the tightness of federal funds, there is not coffee outside, but there is downstairs, and we'll reconvene in 10 minutes. Thank you.